as you know, the San Antonio Breast Cancer Conference is our biggest, conference to discuss an exciting novel targeted therapies and, big treatments, potentially practice-changing decisions and new phase 3 trials results, they're discussed, anything related to breast cancer. For my special interest, though, I am more of a translational researcher who's doing early phase trials, phase 1 and 2. So one of the discussions that I was involved in was the novel targeted therapy, especially focusing on PI3 kinase and then AKT pathways. And so there were, several exciting posters, including the posters that I have discussed, as well as some of the other ones that were covered by the general session. So a few of the items that I could take on from the take-home message from those discussions and the general sessions that were involved is certainly this is a new era, the targeted therapy in breast cancer, especially in HER2-negative subtypes, for example, ER-positive or triple-negative, has boomed again. There were like 1 or 2 large studies that were being presented, over the years from targeting PI3 kinase, such as SOLAR study, or, there was also the AKT inhibitor study that we were waiting. So those results are coming in. I think the results are overall promising that this is one of those lessons that targeted therapy in breast cancer is finally getting into better shape in terms of more approved protocols or the combination therapies, or actually new potential, upcoming possible registration path. Although some of those phase 3 results were either negative or pending. So that's one of this area. I think as we are having more of those targeted therapies coming up, one of the things that we also have to pay more attention is how we define those target groups. So in phase 3 studies, for example, the opportunity, trial, the cohort A, they were selecting patients with the PI3 kinase and then AKT altered target groups. Unfortunately, that study had been coming back as a negative study. So basically, the patients who had an altered pathway, by adding the AKT inhibitor, that did not improve the progression-free survival. However, I think that there could be either one of those two things. Number one, either we are having a not sort of accurate way of measuring this AKT inhibitor, predictive pathways potential. Number two, those targeted therapies, sometimes it's very hard to get the positive signal. Sometimes this requires a very large number of patients to actually detect the signal of the potential benefit. But then, you can also argue in TNBC, who has a overall bad prognosis, you have to truly have a significant improvement of the survival. Otherwise, it's meaningless clinically. So those are but then when you're going into more of the earlier studies, which I cover in the poster discussion session, there were a lot of promising agents, for example, like neratinib in the targeted ERBB2 mutations, the triple combination of neratinib, fulvestrant, and trastuzumab had more than 45% overall response rate, which is very exciting. And similar pattern has been shown in some of the others, so the new upcoming PI3 kinase, that's, triple combination of the palbociclib, capivasertib, and the fulvestrant also shows pretty, significant 40% response rate, which is going to be tested in the future studies.